Right, hi everybody. Well, the time now is, hang on, I can hardly see. It's 5 in the morning, and guess where we are? You've seen them on the telly. We're in the nerve centre of the London Ambulance Service. Have a look around the room. Look. No. We can't show you that because we can go like that. We can go like that. Okay, there you go. You can't see. And this is Andy, my new best friend, who's running all of the ambulances in London. How's it working?
This is one of two control rooms we've got managing London at the moment. Even at this time, 5:10 in the morning, we're still receiving about 100 calls an hour from members of the public
100 calls
needing help of one description or another.
100 an hour? 100 an hour? There's 60 minutes in an hour. That's more than one a minute.
Yep, definitely. And at the moment, just have a look up there. We can see all the green circles are resources that we've got available across London at the moment
So
to
that'll
deal
be
with that call flow.
ambulances or bikes,
Ambulances, bikes, cars.
push bikes.
No push bikes at this time in the morning, but the majority is either ambulances or cars at the moment.
Oh, it's moved.
Yeah, it's real time, so it'll update about every 15 seconds. And
And is
it'll
this the
track the
software
vehicles.
where you park the ambulances up in the places where you think they're most likely to be used?
Yeah,
Yeah.
so we can set that up to look at what the predicted call
That
volume is going to
software was
be.
invented by a man called Paul Smith. Did you know that? He was an architect.
Paul Smith, yeah, I know Paul very well from years back. He
Yeah.
was a disciple of Jack Stout from the States who
That's right.
brought in the
Yeah,
system
he
status
developed the
approach.
system,
Yeah.
yeah.
So I
There you go.
did a lot of that.
We both
at
know the
uni.
same guy.
We do.
Yeah.
Very good guy, Paul.
Yeah.
Played golf with him many a time.
Yeah, he loves a game of golf, as you can tell. Go on. Yeah.
So that's at the moment London. We cover pretty much everything inside the M25.
Yeah.
From midnight to midnight tonight, we'll deal with about 5,000 calls coming through here and our mirror control room at Bow. So London's pretty much split diagonally through the middle. So we've got the two control rooms for resilience. So if you call, you could go to either the control
So
room.
if something happened here, you've got the other one.
Absolutely, we can fall back to there if this
Yeah.
place was flooded or something else, and vice versa. So at the moment, I've got about 80 staff across the two sites, looking after London. About half of those still answering calls, the other half dispatching the resources and making sure the resources are in the right
Now,
place.
where are the people when people ring in? They say, "My mum's having a baby on the kitchen table." Where are the people that say, "Well, just keep calm, darling. I'll show you"?
They're
what
all
to
down
do"?
there.
I see. Are they
So that's-
specially qualified? Is that a special qualification?
It is. They all go through. We use a software called Medical Priority Dispatch, which is a triage algorithm, which gives us a series of structured questions.
Yeah.
So that means it doesn't matter who you go through to, you'll get the same series of questions and the same level of care provided.
Yeah.
The same instructions afterwards to help you deliver a baby, to do CPR if you need to. So I've got about 20 staff here and about another 20 staff at Bow at the moment,
Yeah.
answering calls from members of the public, triaging those calls. And then once the calls are triaged and we know whether it needs an immediate 8-minute response or it's something which one of our clinical colleagues can phone the person back and advise them if they've got a headache or a stomach ache.
Take an aspirin, pull yourself together. We're
That's-
busy.
That type of thing.
Yeah.
Maybe more diplomatically put, but yeah, very much along those lines. So once it's triaged, it comes up here for either the dispatch of the ambulance or a fast response car, or for one of the clinical guys to call the person back and give them some advice and guidance over the phone about how to access the appropriate healthcare in the right way, which makes it easier for them in the long term.
It's really come on enormous, isn't it? What you can do on the phone.
And it becomes so complex now. Long gone are the days where you'd call in, we'd send you an ambulance straight away. Didn't matter what was wrong with you. Now it's about looking at what the problem is, how best you can access the healthcare you need for the problem you've got at the moment. So it may be phoning you back to say, well, when the chemist opens in a couple of hours, pop round there and get some paracetamol. It may be that you're phoning me with chest pain, so yeah, we send you a car and we send you an ambulance and get there as soon as we can. So and there's a whole middle part which includes the mental health nurses we've now got, which are an absolute godsend.
Yeah, I was talking to some policemen the other day. They reckon that, what is it, something like 60% of their work now is with mental health.
It's a huge
Now, where
chunk.
have I seen somewhere that the ambulance service have got special constables? They've got some paramedics who've been trained as special
Joint
constables.
response unit are you talking about?
Yeah, is it?
So they're medics
is it
who
LAS?
respond to police
Yeah.
incidents.
So we've
Yeah.
got medics.
It's you, is it?
It's medics
Yeah.
that work alongside the borough police officers. So they
Yeah.
have a police radio. So if there's incidents going on within the borough, then they can respond alongside the police to treat the medical aspect of the call.
Yeah.
And again, a massive aspect of that with the police workload is the mental health care, accessing the mental health pathways and being able to deal with
And a
people
large
having a
part of
mental
your
health
work is
crisis.
mental health.
It's an increasing part of our workload, yeah,
Yeah.
very much so, especially out of hours.
Yeah. And I mean, there's been okay. I mean, we all know the NHS is busy. We've been to 3 A&Es tonight, and we've got 2 more to go to. Huge difference in. I suppose I can tell you where we've been. We've been to Surrey, right?
Yeah.
3 hospitals in Surrey. We've been to the 3 main hospitals in Surrey. One was on black alert, although we don't do black alert anymore. But you know what I mean by black alert. One was not really busy at all, and one was chock-a-block, wasn't they? So, and all the hospitals were in a reasonable catchment area. Why don't we redistribute the patients to the hospitals that aren't so busy?
There is some effort, especially in London, there is some effort where we do
that
that.
here,
We have a concept called intelligence conveying, where what we do across a rolling hour is look at the number of vehicles that are going to each hospital within predefined parameters which were agreed with each hospital. So if, for instance, Mayday or Croydon University Hospital had an agreed total of 6 vehicles in a rolling hour and they received 8, then we would be starting to look at the neighbouring hospitals to say, are they over the agreed quotas or are they under? So where's the capacity to move these patients within reason? But we also have to balance that with our fleet, because our fleet is designed to operate in a given way in a given area. So we have a set number of resources in the area to cover a set number of calls. So once we start moving them well out of area, so our cover has issues. So it's a delicate balance between the two. And it's all about getting the health economy more joined up and taking a more whole system approach,
Yeah.
and working together to say the patients at the centre of this, where's it best for them to go, but also where's it best for our resources to end up for the next patient so they're not waiting for a long
Yeah,
period of time.
so it's a giant game of 3D chess.
It is, absolutely, that's one of the best descriptions, yeah.
Yeah.
Absolutely.
Well, that's good. Well, we're going to have a look round and we'll periscope some more. Sure. A really difficult call. Can you ask for help?
Absolutely.
Someone to listen in? Or...
Absolutely, no one here is by themselves. So if you get a difficult call, everyone's trained to deal with the difficult calls. Hysterical callers, children, the elderly, the confused, mental health issues, traumatic scenes. So they're all trained to deal with those in a non-visual environment, which is very different to being on scene and trying to manage
So where
something.
are they trained? They're trained here or
Here.
on the job? They're listening in?
So we'll do some training in our training centre. So there are a number of weeks there, learning how to use the system, going through different scenarios, testing each other, and then they come in here for a period of time where they're then sitting with a trainer to go through a number of shifts.
So, Andy, will there be a paramedic to start with or
No.
an ambulance person?
No, these are effectively, for lack of a better definition, civilians which apply to do the job, and then we put them through training to do this, which means that our paramedics and our clinically trained staff can then be dealing with the patients and talking to the patients and going and responding to them.
So yeah, I mean, this is an interesting point. So these are, as you put it, civilians who've been trained to do this job.
Yeah.
Why is, I don't want to get you into sort of complicated territory, but why is 111 not being able to copy what you do? They've got themselves into a real mess, haven't they?
I'm not an expert in 111, but they work on a very similar basis where they have call handlers that will take the call and field them to start with, and then clinical staff at the back end to then deal with more complex calls. For me, a lot of it within the ambulance service, and my understanding is in the wider healthcare economy, it's purely about volume. It's purely about people being able to access the right healthcare in the right way at the right time. And if we can get those pieces of the jigsaw together, then it becomes a lot easier. At the moment, people don't know how to access healthcare at the right time in the right way.
It's too complicated, isn't it? I mean, you can argue that we've given the public too many choices. You've got a walk-in centre, you've got a a 24-hour out of hours, and why don't we just put it all in one place and call it a hospital?
Or have one phone number to make it less.
Yeah.
And being here, you're talking
let's
about
change it.
111,
Yeah.
where the London Ambulance Service manages 111 for South East London. We've got some really good dovetailing in place, some really good exchange of information, a data link between us to pass calls, so we can access the end dispositions in both directions far easier. And because of that relationship, there's a much smaller referral rate from 111 escalating up to us than the other 111 providers. So there's a lot to be said about good joined up working.
Well, it seems to me it's the training. I mean, you've got to know what you're doing. And if someone rings up and says, I want an ambulance, you really do have to know what you're doing. And you say, well, do you know what, we're not going to send an ambulance.
Yeah.
I mean, that is contrary to every risk analysis that any manager ever does about anything, isn't it?
But sometimes if you phone up and you've got a really bad headache, and we triage you, we make sure you're not having a stroke, that there's nothing else serious going on. What's best for you? Is it best for you to say, if you just hold on a couple of hours so the pharmacy opens, get someone to go around, get you some painkillers, stay in bed, stay in a nice warm home, stay with your family that can give you some care and support
reassuring,
you?
Andy. I feel better already.
Absolutely.
I'm bringing you, Andy, next time we get a headache.
The opposite,
Stop sneezing.
the opposite is the old-fashioned way, which people want. I phoned the notes because I've got a bad headache. Now I'm going down to the A&E in the ambulance, thinking I'm going to be seen quicker, which I'm not, and now I'm worried about the 4-hour waiting time because I'm going to be here for such a long time.
You know, this really connects with stuff that we've done already this evening, or beyond the other films that we made tonight. In that, you know, we say to people who run A&Es, you know, why are you so busy? And they say, well, it's obvious people can't get to see their GP. You know, and we in the A&Es that we've been tonight, it's not full of little old ladies. I mean, hospitals are full of little old ladies, but you go into A&E, 25 to 60 age group, doesn't it? Smacks you straight in the face. You look at these people, these young, they look all, I mean, I know it's a difficult thing to say, but I mean, they look all right. You want to, I've got this overwhelming curiosity about life, you know. I can interview a milkman in a phone box, you know, and find it interesting. But, you know, I want to say to these people, why are you here?
And I think that's, as you say, what's changed now is that if you call 999, you're not automatically going to get an ambulance sent to you. And that public find challenging.
Well, but it's been driven, isn't it, by austerity, really. This policy has been driven by austerity because too much demand, not enough resource. So we've had to be more cunning about how we use the resource.
I wouldn't say cunning. We've become smarter about what we need to deliver.
Well, and as an ambulance service, we have the largest amount of calls that we close through a hear and treat. We've invested hugely in the clinical hub, people who can ring back and do that safe assessment and close calls down there and then. Good advice and signposting, etc. You know, we are the best in the country doing that. Very, very proud to say it. But it's challenging for people.
And so you were all on the television. Now, what was it like to be stars of the telly?
Yeah, I wasn't. Behind the scenes, that's where the best place to be.
We're really pleased with how well it's been received.
It's a good expose,
Very frank,
and it's an honest and frank picture of where the
What
service
did you
is.
say to the people who took part? Do you say what you like?
We briefed everyone face to face just to support them because obviously it's
What
quite
does
difficult.
code mean? We'll give you a smack.
Not at all, not at all. One thing we did do when we decided to do this documentary is we knew that we could trust our staff because they're really good at what they do. So that was never a concern when deciding to do the documentary. We knew that they give great care, they're compassionate, they're caring, and all of that happens here in the control room and out on the road. So there was no concerns
Do you
in
know
that
what
area
really
at
struck
all.
me though was the one that they did when the two paramedics were having a conversation in a cab about the meaning of life and when they were going to die. There was this whole philosophical thing. They dealt with some particularly stressful thing on shift.
Having been out there as a parent myself, stuck in the cab with my crewmate for 12 hours, and spending longer with my crewmate than I did with my family. Some of the depths of the conversations you go to and some of the conversations you have And if you spent a shift in here listening to the staff, you have conversations which you wouldn't dream of having in any other walk of life, because people would look at you and think, what?
But I thought that these two were going to get into niche or something. You know? I mean, it's just such a deep conversation. Heidzik, you know. What do you think happens when you die? Well, I don't know. I'm thinking, you go, it's a regard and it got. I was thinking, this is really good.
And sometimes it's a coping
Do you always
mechanism.
work with the same person?
It depends whereabouts in your career and where you're working. A lot of people work with the same person, but when you're fairly new, you're what's defined as a relief, so you go and fill the vacancies in different places. And then you get onto a permanent line with a long-term colleague, and that's when some of those really deep and meaningful conversations occur.
I can imagine.
But when you think about it, the amount of we see a warped side of life, we see a warped side of society, whether we're here or in hospitals. You see a side of life that most of the public don't know how to cope with. You see death, you see trauma, you see hysterics. And so you need a way of coping with it, of dealing with it. And one of those is to have those deep and meaningful what if but why conversations to try and
You
understand.
must eventually it must get you. We've got a short piece of film of two junior doctors where they explained one Christmas what had happened to both of them, and they both lost patients on Christmas Eve, and how that had impacted them over Christmas. And you kind of don't think of that, do you? You think doctors deal with death. Actually, they don't, and it leaves a fingerprint on them. You never get annealed to that, I don't think. It must be the same for you.
My wife always says to me, is if I've done an operational shift out on the way, she says to me, I can always tell when you've done a kid. I can always tell because you're different. You can't explain it before, but you're different. It's a different you that comes home.
It must absolutely leave a fingerprint. Now, what are these big? I tell you what, I'm a bit of a one for a graph on the wall. I have to say, I do like graphs on the wall. What's that pie chart?
The one over there shows me how many calls on the floor now. So the green ones,
Can you try for me to unloosen the blankets, stand at the side of the bed, pull the sheets and even onto the floor.
So the green ones at the moment.
The green's good.
Yeah, that's so. What are they? They're doing their Tesco's
guys
order, or they
standing up all,
downloading?
they wish. Yeah. But in terms of managing it all, do I need to put more people down here? Have I got enough staff? Is that whole balance?
Now it's interesting you got the news featured largely, because I suppose in London you will be news driven often, won't you?
We are very news driven, and staff in the room want to know what's going on.
Yeah.
And anything that's high profile, we're going to be running event control for it, having the news to see what's it, be it BBC or be it Sky News, both off.
So we had the Olympic heroes, didn't we? In Trafalgar Square. Was it? I don't know what day it is. I've been up for 24 hours. The day before yesterday. Did you make any special provision for that, or did you park anybody close by?
We do have an event planning emergency. What's their
It's
name?
an emergency
EPPR.
planning response, and they'll look at the event with the event organisers, and they'll score that against a guide which is issued. And
So
then,
something like that wouldn't thought to be contentious.
no, it'll be looking at things like the number of mixed families there, or is it males only, what's the age group, where is it going to spread out, is there a risk of anything happening, and then according to all that, just as with football matches, they'll decide, do we need to put staff in, is a first aid provider that's employed there sufficient, do we need to put an
So would
officer
you
in
have
to
had somebody
manage?
in Trafalgar Square?
We would have had an officer there just monitoring what's going on and just
Bigger
liaising
events
back.
obviously take up a lot of planning. New Year's Eve, Notting Hill Carnival, the Marathon, Pride, big, all Wimbledon, all
And
of
of
those
course,
events.
underlying that, I mean, I'm sure it's something you won't want to talk about, but it's worth commenting about the fact that you've got the London terror alerts as well, which sit, I imagine, underpin.
Underpins a lot of stuff, and a lot of the risks that you're looking at, be it people that park their cars, and I think a lot of the time the public don't think about it. You park your car somewhere, you shouldn't park your car and go off shopping. What's the first thing that people springs to mind? You leave a bag at the side of the pavement and you walk off, someone walking past is going to raise an alert and say that shouldn't be there. So there's lots of things like that which do get raised, and
Yeah, and we
Now
work so
look, can I
closely.
just say, look, my pie chart. I do love a pie chart. It's gone very red. You don't want me to pick up the phone and offer polite advice to someone.
I've
do
got
you?
a spare headset if you want,
Yeah,
one later, if
just-
you want to give it a go.
I think so. You know, what's the matter? Pull
Shall we-
yourself together.
Shall we pop upstairs and we can have a look at the dispatches?
Let's do that. We've moved now to another part of but there's still a nice chart on the wall. We'll have a look at that in a minute. But okay, what are we doing now?
This is our clinical hub aspect. So this is paramedics and nurses, experienced paramedics and nurses, which we bring up to the control room, which for the lower priority calls, they'll call the patient back, have a discussion with them, go through a more refined triage, identify a care plan for them so they can signpost to right health care, be that going to the pharmacist, be that taking yourself to A&E, or going to a minor injuries unit in a few hours.
So these ladies and gentlemen will be nurses
Yep.
first, who then decide they want to come and work
Yeah.
here as a call handler.
Yeah.
Yeah.
Call handler, well, it's maybe an unfair term,
Sorry, it's a posher word. It's 5 in the morning. I can't think of it.
but a clinical advisor.
Yeah.
So they'll be here to call back, talk to the patients, identify a care
And
plan
they're
for
full-time
them.
staff.
Full-time staff, the majority are full-time. A few of them work part-time with us and part-time elsewhere.
And it's interesting that it's all uniform. Really, it doesn't have to be. Does
It's,
it?
well, it does to a certain extent. At the moment, it's not an issue. Everyone knows me as the manager and everyone knows the clinicians. But come an incident, comes something which scales up very, very quickly. You need to have that authority, the rank, the role to get the emergency under control, to get the event control rooms, incident control rooms up and running, so staff know, and it may be staff that are new to working with me, but they need to know the position. And the same, we would have high-vis jackets on with
Provides
the roll
the
on the
operational
back.
framework. Yeah.
Absolutely, that's the word. Yeah, at 5 o'clock in the morning, I couldn't find. Yeah.
I'm doing my best. Stay with me. Stay with me. Right.
So yeah, so on a day-to-day basis, no, you don't need it, but there are moments in time when it's fundamental to what we're doing.
Right. So. what-
So just talked about mental health.
Yes.
We've done our
So,
pledge.
okay, I mean, mental health is a big issue, we know, because we've spoken to the police and they tell us that it's I can't remember the figure now, 60 or 70% of somebody causes mental health things. And you're working much more closely with them.
Yes,
Because
so
a police station is no longer a place of safety for a child either, is it? No. Can't put kids in cells anymore.
and we do everything we can to avoid putting somebody with a mental health issue in custody as
Yeah,
well.
yeah.
We work very, very closely with the police. In terms of the service here, what we recognised a year or 18 months ago really was the increased number of calls from people in mental health crisis. So we talked about our total numbers per day, 5,000 calls, around 400 from patients suffering a mental health crisis per day. So in terms of being able to deliver care in a different way for those patients, we decided to employ mental health nurses directly within the control room.
So they will be normally community psychiatric workers of some sort.
So they're
mental
all
health
they're all the high-end psychiatric liaison nurses. They've all done emergency department, psychiatric intensive care, so they're used to dealing with really
Yeah.
high-end people in crisis.
But they're working blind on the phone. It's an extra
it's-
skill.
Yeah, absolutely. So we've had to do very careful selection of people, obviously, but also the training.
It's people who can do this job with their eyes shut.
I mean, they're amazing, and we've got two actually on shift today. So they will take calls directly from patients. So if the call handlers or any of the staff here are talking to someone and they're really quite worried about them, they can pass them to the mental health nurses. The mental health nurses can also look in and see if a call handler is tied up on an extended call, and they can listen in and think, oh, actually, I can dive in and help now. But also crews at sea more often now, where we're struggling with a capacity act assessment, use of the Mental Health Act, those kind of tricky issues. Crews can ring in and say, can I speak to one of the mental health nurses, and they'll give advice.
So, I mean, when it comes to sections, the paramedic can't do that.
No, only the police can implement a 136.
Yeah.
So our commitment is we've been 18 months now. They're fantastic. About 18% 18% of these are high-end crisis calls, but 18% the nurses are able to close with a hear and treat option and refer, and that's saved over 1,000 ambulances in the last year being sent. But also those patients absolutely would have been conveyed to an emergency department because there's very little out of hours services.
And that's the wrong place for them, isn't it?
And the patients tell us that.
Yeah.
So that's been a resource saving, much better experience for patients, and we want to increase the numbers of staff we've got. But what we also want to do is get them to work in a slightly different way as well. They're very keen, and with the joint response unit that we've just been talking about, with our staff who have the radios and go out and respond to calls, the mental health is going to start working with those teams. We know those teams go to a very high proportion of mental health calls. As you said, the police, it is a large majority now.
It's hugely distracting for them.
Yeah, so we're
What
going to
about
start
prescribing? Because I see 111 is now going to start referring patients to be prescribed directly from pharmacies.
Oh, I haven't seen.
Yeah, no, you're not.
No.
Oh well,
I'm behind the times.
I bring the bearer of news. No, it's an announcement. I think yesterday. So it might be something that you could do. I suppose you could do that.
We're looking at the moment at employing a full-time pharmacist to work with us. And one of the issues we have is people with polypharmacy needs who are on lots of medications and ring in. Actually, one of the drivers could be about the amount of different medications they've got and potential interactions.
What are your skills then? Because this is a very complicated job. Are you a clinician? Or?
So I'm a clinician. So I'm a nurse by background.
Yeah.
I've been here 2 years, but I spent 25 years in the acute sector and the last 10 years running the major trauma centre in the emergency department at King's in South London. So used to.
Well, you're used to this catchment area.
Yeah, used to the catchment area.
And it's good. What about language? Is that an issue for you?
In terms of the number of different
English
languages.
is not the first language.
No.
The Homerton translate everything into 137 languages.
Yes, so we use Language Line a great deal, and that's absolutely available here. And we know which are the kind of top 10, 12 languages we use, but we have to put everything on our website in multiple different formats. Our patient
You
information.
don't employ
leaflets,
specialist
etc.
English.
No, we use Language Line. It's absolutely 24/7, accessible and very high quality. So, some staff, are bilingual, another way, but no, we use Language.
Well, isn't that interesting?
And we have a mental
Excuse
health.
me, I'm a sucker for a graph. What's a graph?
Andy,
What's that one?
What's that one?
This one.
Yeah.
Do we want to walk down?
It's rather nice colours, aren't they?
Come this way.
Oh, it's gone. If you want to speak to Irish, the mental health.
Ian pushed him into a phone box and he drove the FIU.
Oh, it's gone now.
It'll be back. I hope. It should be back. Yeah. There we go. It's just when it refreshes.
Right.
But
So what have we got
It's
here?
about information and keeping on top of everything we've got going on. So this tells me at a glance how many calls that we're holding currently across London. And that may be holding calls because we haven't got ambulances to send. It may be holding calls because we're waiting for one of my clinical colleagues to call the patient back and have a discussion with them. But it's just a heads up to say, at the moment, this is the number of calls that we're holding.
What does green mean?
Green is just
Oh, these are just the geographies.
so when it comes back. So that was at East London.
Yeah. So that refreshes every so
It refreshes. So at the moment we've got 2 calls in the Chubb waiting for a call back.
Yeah.
2 calls in the West waiting for an ambulance response. That may not be a category A life-threatening emergency. That's more than likely somebody that just needs an ambulance to provide transport to hospital.
Right.
So there's no alarm bells going off. And here, this tells me the priority of the calls that we're holding. So red 2 is the serious calls, so that will disappear in a minute. Sometimes because the activation is so fast and the refresh rate of this, it's already dealt with before this refreshes. C4, which is our lowest priority, we've got 3 calls holding, so that can be waiting for colleagues to call back. And then this tells me of the calls that we're holding, how many have had a call back to talk to the patient, to advise, and there's a time limit which we hold the call for before we'd have that call back. So that just gives me a heads up to say we need more people to do the callbacks and advise people there's going to be delays or we're fine. And then the last chart here is our what we call held calls history. So we know our data. The blue line is how many calls we were holding. The red line is tonight, and you can see how they may not be on top of each other, but the trend pattern is the same. So we know we're dealing with a workload which is
So
familiar.
this is time, is it? That's 11.
So that's 8 o'clock last night.
Last night, 2, 4, 5,
Through to
which is where we
5
are
o'clock
now.
now. Yeah.
And that will be just London going to sleep, I suppose.
Yeah.
Yeah.
So we get the peak in the evening. People get home from work, realise they're not well.
Or perhaps coming home and finding a relative.
Absolutely. Or having accidents on the way home, going out drinking, having an accident, or
Yeah, you
overindulging.
can tell when the pub's shut, can't you? Yeah.
Absolutely. So, and that's why it's very predictable. When you look into it, you can understand the data, and then what we'd expect in a minute, you can see the spikes as people start to get up and go to work, and the cycle starts again.
You'd be interested in that.
Fascinating.
Yeah.
I love-
Shane's business
I
is
love the data.
IMS Maxims, and so he does data right across the. It's good.
It's mainly for acutes and ED departments, but the idea is to help ED departments. You could run an entire country,
Yeah.
size of Wales or Scotland and New Zealand, and be able to see what every individual is doing and scale up.
Yeah. And for us, the data is essential because the incoming call volume, and then you take about a third off, and that gives us the number of incidents that we're going to respond to. Take a third off of that, and you'll get the number of patients that we'll deal with. So each stage through the process, the data fundamentally underpins how many call handlers do I need, how many dispatch staff do I need.
What's so interesting about this is the use of data, because the NHS as a whole has the best data set in the world. GP's records since the 5th of July 1948, hospital records since 1950, shimmies and HSMRs and all of that data is available. We don't use it really, do we? I mean, not to the extent that we do.
No, we're not joined up.
No, who got sick? What did we give them? Did it fix them up? What did it cost? Do we want to do it again? 5 questions that we can't answer, really. But here you crack the data, haven't you?
We've cracked, so in terms of visual management and in terms of live data, the analysis that's ongoing as days change, as weeks, months, absolutely. One of the challenges I would say we have is accessing patient records, for instance. So in order to have a fantastic hear and treat rate and do that safely with our clinicians, being able to actually access somebody's record would be great, to have their crisis care plan. So we can see end of life care plans, people who have a Coordinate My Care plan created, we can see those.
Now,
Otherwise we
where have I
can't
been?
see.
Is it at the Isle of Wight that they can do that? I think it is. There's a call centre there at the Isle
See,
of Wight.
the Isle of Wight have got a really good model because they're so
Yeah.
small.
Yeah.
The
One
ambulance
trust.
service, 111, the hospital, out of hours is one trust. So there's no issues about
And it's
sharing
one
data.
call. I've
Yeah,
been there. It's ever so good.
absolutely.
Yes.
And that gives you control of all the information in both directions, escalation, de-escalation. Is it urgent? Is it non-urgent?
Yes.
What's the reality? What's the patient's perception when they call? So you've got everything in one hub, and that's, as Brian was saying, we're very good here with the data we've got, but we're only one spoke in the NHS wheel in London,
Yes.
and we need those spokes
Well,
to join
then
into
we've
the
got the
central hub.
governance issues, haven't we, with that? I mean, if you look at Healthy Liverpool, where they have done a really big deal on data, they got 3,000 data agreements to make that
Yes.
work.
So what we're absolutely pushing for at the moment is a pan-London data sharing agreement.
Yeah, but then if you
so
look at the Caldecott, say the latest report, I mean, I'm sorry, Dame Caldecott, if you're listening, darling, but it's not very helpful, the latest report, is it really? Because it's still fanning about. Well, I mean, why she doesn't say we just got to share data and get over it, grow up and get over it, I don't know.
And you can imagine us as a London Ambulance Service, you've got 32 CCGs, 9 mental health trusts, all the
Yeah.
acute trusts, and then every individual GP, social care, etc. I could spend my whole life just doing data sharing agreements with individuals.
Yeah.
So
But you can't do that. It won't work across London. But you know, I think the
they're
public.
committed to do a pan-London.
But I think the public think that you can do that.
Yes, no, I think the public expect that we have the access to the records. And again, when we speak to mental health nurses, to be able to do high-end crisis assessment and not be able to
Look at
know
a care plan,
that,
yeah,
yes,
absolutely. Yeah.
and people do expect that we can see what their GP saw, what they had done in A&E, what drugs they're on from the cardiovascular team. They do expect you can see that.
It's when you come and you look at this like firsthand, and we have this privileged insight into how you work. These data things, which are arcane, really, actually are really very important.
Very important, and it's the block to moving care on.
Well,
to that
Fiona, darling, you've got to pull your finger out. We need a better agreement, don't we?
Thank you very much.
Okay, fine.
hold your staff.
Listen, a lot of people say to me, why haven't you got a knighthood, Roy? We just sing. Yeah, how do you do it?
Well, I don't know. After now, I keep asking myself, how do I do it?
Yeah.
I suppose it's something that's in you.
Yeah, you have an insight into people. I mean, you know, dealing with them face to face is very different, isn't it, than dealing with them over the phone?
Well, I would say it's not that difficult. Yeah, you just.
But if somebody's, you know, very distressed and very upset, how long does the average call take?
It depends. If you've got a good rapport, usually in about 10 to 20 minutes.
So a call might be 20 minutes. How many calls would you take in a shift? You do 12 hours, do you?
Yeah, on an average, it's about 19 to 20 calls on a day. It depends on the day. If it's quite busy, it's big plus.
It's very stressful.
It is very stressful. It is very stressful.
You must go home exhausted.
It comes with the job.
Yeah, well, I imagine there's an immense amount of satisfaction in it as well.
Yes, yes.
So where did you work as a mental health nurse?
In a PQ, psychiatric intensive care unit in Nelft.
Oh yes, well we visited them. Yeah, we went and saw them. They're a great trust, aren't they?
Yeah,
Yeah, Nelft have done very well. Yeah, they got a nice. So what's the name of the chief executive there? Good guy, Paul. Brown. Yeah.
But we stole you.
Yeah.
There's no going back.
Yeah, no, but it's a good. I thought it was a well-run trust and very nice
it
people.
is, yeah, I do.
Yeah. So this is a big change. Why did you come here?
I needed change. I needed something different.
Yeah.
So we are the pioneers within London Ambulance Service.
Yeah. Well, mental health issues. We were talking to the police. They were saying that sometimes 70% of their calls can have a mental health issue involved.
If not more than that.
Yeah.
So the mental health managed about 19 calls a shift.
We were just saying.
Yeah, highly complex.
So what was your first name?
Iris.
Iris was saying, and I said, it must be very stressful. She said, yes, it is.
That's why we have to, and that's why our pledge is to break up this work, which is stressful, and the risk element and the governance in terms of doing it over the phone. To be able to mix that now with front line, with vehicles to actually see people face to face, I think is important. Because after 18 months, I think we recognise that this is very full on.
So that's your
we want
Fab
to change
Change
it.
Day pledge?
Absolutely.
As an organisation?
Absolutely.
Fantastic.
It's a great
It is a great.
Yes, I miss the face-to-face. I miss actually something.
What about FaceTime? Would that help to be able to see people? Have you got a smartphone? I'll FaceTime you.
Do a risk assessment. After 24 hours of no sleep, it might not be great.
Do that, can you? Why not?
No, that's something certainly that we've been
If
talking
you
about
can
Skype.
say to someone, hey, have you got a smartphone? Yeah, I'll call you, let's do FaceTime.
I think how we use Skype and systems like that in terms of telemedicine and introduce that more into consultations.
There's a lot of old nonsense talked about patient confidentiality and it's an open system and but there's nothing to stop it happening. There's no governance that says you can't do Skype or FaceTime.
No, and it's certainly used in other ways, and from a major trauma centre point of view as well, with burns and things, being able to see things. I've certainly worked with elective surgical clinics where afterwards they do post-op through using Skype. GPs are using Skype. One of our local GP collaboratives uses lots of telemedicine. So it's how we again, it's about integration.
You never know, you might be ringing me. Listen, I don't know how you do it. I'm a big fan. Well done.
To assess, you have to 24 hours on the road, no sleep at
My brain is completely scrambled. There's nothing left. Yeah. We've had a good day though. We've been everywhere. We've been helicopter. We've been to where did we start? We went to Birmingham.
Birmingham, the National Association of Primary Care Conference. We started there at just after 8 yesterday morning. Then we flew to Norfolk and Norwich Hospital. And we flew from there to Northumbria. Then we flew to Chester and flew back to Birmingham. Got in a car and we went Milton Keynes. Frimley Park, Ashford in St Peters, Guildford, Brighton.
We went to a hostel for homeless people that's partly run by the
Yes, your colleague
NHS.
was saying that it was amazing.
Phenomenal.
Yeah, really.
All mental health issues, substance misuse, men and women trying to get their lives straightened out. And they run this thing as a third sector, social enterprise or something like that. And of course, now it's all about cuts in funding and yada yada yada. All the wrong. They're doing fantastic work.
No, the cuts in social care and mental
So
health.
Mental Health's got 200 million, isn't it? Got more money now. What are you going to do with it? Go shopping.
I was on a holiday.
They could give us some. Hopefully, 24/7 single point of access telephone advice line, so that the mental health nurses can ring a single point of access and make it easier for patients to navigate as
Because
well.
not many of the mental health patients used to go into A&E. When I'm in a crisis, I don't want to go to A&E.
No, it's the wrong place. A&E is the wrong place for almost everybody, particularly elderly, frail people with dementia as well. That's the
Yes.
wrong place for them.
And one of the things interesting talking about the third sector, because we know there's cuts, so the work we're doing there with the third sector in lots of different ways, and with the Samaritans and with Mind, Alzheimer's UK, Dementia UK, etc. We've got to look at other pathways. Frail elderly is a huge issue for us as well. Dave manages frequent callers, or has done for the last year, and frequent callers
You can
socially
almost,
isolated.
you can the
elderly.
frequent ones. Look at the data. You can almost predict, can't you, that they're going to come back.
Absolutely. So social isolation, loneliness, and as we've linked in with again agencies such as Silverline, Age UK, British Red Cross, so that we can refer on to another provider who can then do the follow-up. A lot of it is talking and people being lonely. So move to a more appropriate. The person gets surrounded and there's governance, etc. But they're not then reliant on the 999
Interesting what
service.
you say about loneliness and all the rest of it. All this business about people want to be treated in their home. And I know they don't. They want to go in hospital and be looked after and talk to people.
My diary is now full of meetings that say lonely and socially isolated, because there's different meetings with that title. So I go along to meeting after meeting about the lonely, socially isolated.
So Dave, how do you deal with the repeat callers that you obviously get to know relatively well?
So I suppose a lot of it is trying to get to that root cause of why that patient is calling for help so much. Is investigating and exploring all of the roots of crisis and then trying to apply the
The
necessary
London
support at that
Ambulance Day
time.
Centre coming up here. I can feel it coming.
I just think it's helping patients to sometimes manage that level of complexity, which I think you've said before can be quite prevalent. So any way that we can support patients to do that also helps ourselves to be able to utilise all the resources we have there, such as, like I said, the primary, secondary, tertiary sector.
Which brings us back to the data sharing.
brings
So
us
I
back
love
to
the
the
fact
data.
you're putting that out, because we know who all of our frequent callers are, but it's about how we can share that data with the CCG, the individual GP, the care home, etc.
I think Fiona Caldecott is far too cautious. And I think the public would expect her not to be so cautious. I can sort of understand that. She's a very nice lady, and she's very amused by the fact that the Caldecott report is actually her husband's name. She's Mrs. Caldecott. They always have a laugh about that, apparently over the Sunday lunch. Anyway, she's got this one wrong, and we'll tell her.
Thank
Okay?
you
So
very much. Glad it's coming from you.
I tell you what, I'm in awe that you can do this on the phone. You talk to anybody, doctors working in hospital and all this bit, even GPs, you say, why can't you do your screening on the phone? Half the
Well,
GPs
and to
find
date, we've
anywhere
not had
near
a
it.
single serious incident in 18 months and over 6,000 patient contacts. Not a single.
Maybe it's
adverse
just, I mean, it's
incident
easy to be
complaint.
critical of people who don't want to work on the phone, and I do get it, because I think there's a lot of it's about training, isn't it? Because you've been trained to do this, whereas GPs, are trained to watch the door handle and how people walk in and sit down, and all. There is all of that, isn't there? It's the future.
There's nurses,
I know. Where do you go?
can't beat them.
Well,
Oh
it's
yeah.
like, the paramedics, they are
So who
normal
was on the
environment
telly
we
then?
see
Who's here who was on the telly?
Oh, I don't know actually.
Well, Holly was on the TV just behind you here.
Oh yes, absolutely.
Me.
Holly, this is Roy Lilly. And so, Holly, you got with us.
Yeah, I watched that.
Yeah.
Riveting. Were you pleased with it? It was a fly on the wall, wasn't it? Were you really conscious of the phone they were in?
Yeah, it was the camera quite nice.
Oh, we just got recognised in Sainsbury's.
Did you really?
Oh yeah, a few weeks ago.
It's embarrassing. I was on Newsnight one night and we were talking about IVF treatment, which should have been on the NHS. It was unusual. Yeah, I was in the same, I think I was in the same as the next day. The woman's on the chick and she was showing my telephone. This is not going to go so well. And she said, my daughter's having IVF. I thought, oh God, this is awful, you know. And she said, it's ridiculous. They should pay for it. I could have kissed her.
Oh, really? Oh, excellent. She was. Yeah, you recognise a few people around the room, I think.